Good afternoon, ladies and gentlemen. Welcome to Rhythm Theater 2. Today we're going to talk about a pretty exciting technology that I think is continuing to reshape our understanding of atrial fibrillation and really bring in some incremental improvements in the efficacy of catheter ablation. So the topic of the day is redefining complex AFib management, AI-enhanced mapping, and clinical evidence in the most challenging patients, right? So nowadays, talking about AI is talking about Y2K because it's a sexy term that everybody wants to use. But for the most part, nobody understands what the heck AI means. So what are its implications and how exactly can this be integrated into clinical workflows? I think is a continued challenge. And how do we really leverage this incredibly powerful tool to do more or to do less and do that better, right? I think that's the crux of this. So Volta Medical has been around for a long time. They very promptly try to educate us at every HRS in Rhythm Theater 2. This is my number 3. So you can just tell that they're not going away. They are persistent, and they are trying to make a case for why they belong here in the atrial fibrillation ablation space. So bringing in a multi-parametric AI approach to persistent atrial fibrillation patient, I think is an important facet to it, right? So we all figured out how to take care of paroxysmal atrial fibrillation ever since Michel Hasseguet's original paper of 1997. Taking care of atrial fibrillation hasn't really changed a whole lot as it pertains to paroxysmal atrial fibrillation. You do a good PVI, it takes care of it, and you do well. But then what else have we done to change or move the needle on non-paroxysmal atrial fibrillation is up for grabs, right? I mean, lines came and went, dots came and went, complex ablation points came and went, and we did several things that still don't really pan out because we really don't understand the pathophysiological aspects of an evolving disease called atrial fibrillation. So I think, in my opinion, when you really look at atrial fibrillation and draw parallels to coronary artery disease, there are significant parallels between these two, one being the plumbing equation of it and one being the electrical equation of it, driven by common risk factors like age, hypertension, genetics, diabetes, continued systemic inflammation, and heart failure is an important feature that we tend to forget. So in all of this, how does a continuously evolving dynamic substrate play into a fixed lesion set that we're trying to accomplish? I think that's the disconnect that we have not been able to understand, and that's a disconnect that we have to chase. And perhaps AI is the next frontier that is going to really help us to solve some of those questions. So they've been around. They're probably one of the first earlier companies that really came into the realm, bringing in artificial intelligence and really employing machine learning in answering a very critical question. And in that process, what they have figured out is there is this issue of spatiotemporal dispersion, right? So this is a electrophysiological characteristic that you could potentially use to see, can this temporal dispersion of electrical activity in the atrial tissue in a given space help you understand what exactly is going on in these areas, right? A lot of times you have a point-in-time aspect of the spatiotemporal relationship to this, but can you reproducibly look at the same area in a repeated fashion and thereby identify patterns that could potentially be the drivers, whether you call it rotors, whether you call them drivers, whatever you want to call it. But these are the ones that are capable of perpetuating atrial arrhythmias, and thereby, if you are able to target these things, perhaps you can stop atrial fibrillation from happening or from perpetuating. That is basically the foundational concept on which the Volta system has been designed. They made some significant improvements in an understanding of this. For example, this concept of neighborhood-based dispersion analysis, right? So what exactly does it look at? When you really put up an octopolar catheter, an octary in a given space, can you really create this contiguous space in which you create a regional boundary to it, and thereby you're able to create a neighborhood in which that you can analyze these electrograms and be able to understand the patterns, right? And then you kind of extend that over the entire atrial chamber, you're perhaps able to get to the bottom of that, right? So this is sort of the spatial temporal dispersion component that has been around. And I don't know how many of you actually use this system. By show of hands, has anybody used Volta? All right, perfect. So there are some here. So conceptually, you could use this, incorporate it into any type of mapping system. Doesn't matter whether you're a Carter user or a InsightX user or now more recently even an Afera user. You can conceptually use this and be able to, in a three-dimensional fashion or a two-dimensional fashion, notate those areas of interest where there is a higher level of spatio-temporal dispersion, and perhaps targeting this could be very helpful in this, right? So you have multiple clinical trials that have been done. There were observational studies. There was a large randomized controlled trial led by my dear friend Isabel here, and also some meta-analysis, some sub-analysis, multiple case reports. So there's a lot of literature that has been put out. There are 31 scientific publications that have come out of this, right? And there are over 3,000 patients that have been treated by this. So you're at an inflection point where we got to really figure out how to put this and incorporate this in the clinical flow, right? So I think that's something to think about. The other thing that I really like about is really creating this mini ecosystem of the interplay of electrograms, 3D maps, and continued feedback, annotation, and adjusting your ablation points in a more dynamic fashion by leveraging a remotely situated, exceptionally high-capacity computational power that would help you in incorporating this computation power that you don't have in your own lab, be able to create ablation targets. I think that is going to be exciting, and they're chasing that, and I'm sure that is almost a near reality, and that's going to really help us to really expand our capabilities in the AFib space, and perhaps we can even take it into the ventricular tachycardia space or atrial tachycardia space, right? So we've done about 3,000 cases here in 13 hospitals across the United States and Europe. It is promising, it is exciting, and I think the next steps in this is how do we take this technology, incorporate it into our workflow? There are obviously issues related to third-party payer reimbursement. There are obviously issues that are related to how do we really convince these third-party payers that this is a technology that they got to pay a little extra so that their patients don't have to come back for a redo ablation. I think the financial equation really makes sense. So we'll delve into some of these aspects of it, but without further ado, I'm going to hand it over to Professor Isabel Dyson-Hofer to really tell us more about her study and some of the new things that are there in the pipeline. Isabel.
Sure. Thank you so much, DJ, and it's a pleasure to be here. And of course, your valuable participation in our trial made a great contribution to that whole study. And I'm going to talk to you a little bit about, let's say, a subgroup of patients who is very dear to my heart because I'm a man. So women with, no, I'm not, I don't have persistent AFib, but I might. I hope that I don't get it.
Definitely not.
But when I get it, I'd like to be treated with Volta, just to let that know before we start. Can you? Yeah, thank you. So the Tailored AF trial was, in fact, the pivotal multicentric randomized trial that made us very confident that Volta, the Volta system is of beneficial added value to persistent AFib patients. We had a population of roughly 370 patients in 26 sites in 5 countries. And of note, we had 51 operators, which means that we really tested the hypothesis that this kind of ablation is reproducible even among physicians who were more or less naive to this technique. We randomized these 2 groups of patients into a tailored arm, which means that we did a tailored ablation that was guided by the Volta detected spatiotemporal dispersion areas with additional PVI versus a group where we did just conventional wide area circumferential PVI. And we had a very, very tense follow-up with over 12 months with 3 visits, in-person visits, with weekly sent-in cardiac ECGs and in case of symptoms. So roughly about 19,000 ECGs that were then evaluated by an independent core lab. And you can see that the primary endpoint, which was freedom from atrial fibrillation after 12 months and the single procedure, was significantly more often met in the tailored group than in that PVI-only group. You can see that there were almost 90% of these patients who were treated with this combined ablation of spatiotemporal dispersion and PVI who were free of any atrial fibrillation, whereas in the PVI-only group, there were 70%. If we go further on, what was the workflow in the tailored arm group? Well, we did a biatrial AFib mapping, looked for these spatiotemporal dispersion areas, which were then tagged on the map, and we ablated these areas by trying to circle and connect them. And I think that's a very important point in the whole story of why is this successful. You try really to eliminate these areas of dispersion, or by just putting a line through it, or by encircling this and connecting that to a neutral structure that is not conducting. Well, why are women then interesting? Well, typically they have more symptomatic AFib. They have a poorer quality of life. They tend to be treated with less invasive care, and they are less likely to undergo AFib ablation. And results of women in AFib trials, ablation trials, are a little bit conflicting. You can see here on the left side the manifest 17K sub-analysis concerning women. There it seemed that women have more or less the same outcome that men, but this is a cohort with predominantly paroxysmal atrial fibrillation. In the middle, you see the fire and ice sub-analysis, so cryoballoon versus RF. Again, here, mostly paroxysmal, but some persistent. And you can see that in this analysis, women fared less well than men. And on the right hand, you see that in this analysis also, women had then less favorable outcomes with ablation than men. So going back to the tailored AF trial, we included these 370 patients, randomized them, and we had in the end 42 women in the tailored approach and 35 in the PVI-only group. And if you look at the baseline characteristics of these women compared to the men in that trial, you can see something that is very, very often the case. The women were older, significantly older than the men included. They had a tendency to have higher CHA2DS2-VASc scores, and they had a tendency to have longer AFib history. Not very significant, but still always a little bit on the less favorable side. So it's always the tougher patients, it's always a little bit older, and so on. If you look at the procedural characteristics, you can see it took us the same time to ablate them, but what we could see during the mapping, they had significantly larger areas of low voltage. And that's something that has been known over the years, and that's something also that is always taken a little bit as an explanation why women might react less favorable to ablation, because they have more advanced remodeling of the atria, more fibrosis in these patients. However, and that's very interesting, and that's highlighted in red in the middle, we could terminate atrial fibrillation in the same percentage of women than in men in the tailored group. So the tailored approach seemed to sort of work as well in these women than in men, at least to terminate acutely atrial fibrillation. And what is very interesting, and I was fascinated when I saw these numbers, the amount of low voltage, which is here on the upper graph, is higher in women. Significantly larger areas of the left atrium show low voltage. But the area of dispersion is the same than in men. And that's a little bit counterintuitive. So why we always tend to say, oh, substrate is always low voltage. If there's more low voltage, there's more substrate. But not if you look at the dispersed electrograms. So the amount of dispersion was the same in women, although the left atrial low voltage areas were larger. So it seems that female substrate is beyond low voltage. There's something more complex to female AFib substrate than just low voltage. So what are the results? And if you look at the anatomical group first, and on the left upper graph, you see the freedom from atrial fibrillation only. You can see that PVI is just not enough because these women fare less well with PVI only than the men. So in the anatomical group, and that's what you see on that upper left graph, PVI only worked a lot better in men than in women. You can see that even just at the freedom from atrial fibrillation, women were barely at 50%. And if you look on the right-hand upper graph, freedom from any atrial tachycardia, then you are below 50%. So PVI is really just not enough in women. In men, it's not that bad, but in women, it's not something you want to have done to your mother. Whereas in the tailored group, and that's very interesting, women sort of catch up. So they have comparable outcomes when you use this tailored approach than men regarding freedom from atrial fibrillation as well as freedom from any atrial tachycardia. So the tailored approach seems to compensate for that disadvantage that women have when we start with the ablation. And then looking among women, then at the difference between these two ablation approaches, so that's only the women that you see now in these two graphs, you can see that on the left hand, the freedom from atrial fibrillation was significantly better using a tailored approach in women. And that's also in part due to the fact that women fare not really well with PVI only. And on the right hand, you can see that after one ablation, in contrast to the whole study population, women have also significantly less any atrial arrhythmias than men. So already after one ablation, you can see that freedom from any atrial arrhythmia is significantly better in women. So in conclusion, women with persistent AFib have more low voltage areas with the same extent of dispersion. So it seems that the AF substrate is more complex in these women. And in persistent AF women, both the single procedure freedom from AF and any arrhythmia is significantly superior to PVI alone with a tailored ablation procedure. So the tailored ablation procedure, ablation of spatiotemporal dispersion plus PVI, leads to a similar arrhythmia-free outcome in women and men and sort of catch up this disadvantage that we have as being a woman when you use this ablation approach. Thank you.
So Isabel, that was very revealing because for the most part, I used to believe that the spatiotemporal dispersion significantly increased with scar tissue, but this is quite counterintuitive and quite different than what the assumptions are. So what do you think is happening here? Would the scar tissue have any impact at all in the overall success rates? I mean, I know you're definitely targeting these highly dispersed areas, and once you fix those, your outcomes definitely look better. But the scar, does it have any sort of interplay into the mix with causing more re-intradatal tachycardias down the road, or?
I think it always depends on the scar quality. And if you have a scar that is really just dead, there's no myocardium in it, no, singular myocardial cells that might be activated lately or which represent the slow conduction area, then it might be just harmless. It's not your ablation target instead anyway. And I think that's the quality of scar that we see sometimes in women. You see these anterior walls that are just red and gone and have no signals at all. Whereas I have the feeling that dispersion sort of tends to be there where you have this transition from vital to scar tissue. So in these border zones. where you have a deceleration maybe. And no matter how much scar you then have, the transition zone is always more or less the same amount of tissue. So I think that maybe our definition of AF substrate has to go beyond low voltage.
Isabel, can I ask a question about, this is such an interesting data. I know you said the amount of dispersion was same in men and women, even though there was more low voltage in women. But we see that. But the type of dispersion, where the dispersion was, did you do any analysis on that?
I'm not aware of that. We looked at the general group, and the location of the dispersion was mainly on the roof. The roof was really 94% of dispersion was in the roof, and then anterior wall, and then later on posterior wall. So, and I mean, we all know that first place where low voltage really develops is in the anterior wall. So, and that's also the place where I most commonly find low voltage in the women. So maybe it's this kind of anterior wall roof transition zone that stays the same in women than in men. And no matter if they have war scar on the anterior wall, they still have the same amount of dispersion on the roof.
Excellent. Thank you again for very insightful pathophysiologic data combined with more functional data, and then relatively a pretty elegant solution for what is oftentimes difficult. So thank you for that. So our next speaker is going to be Dr. Michael Bernard from Oshner Clinic. He's going to show us a few cases of Volta AF-Xplorer II integrated into EnsightX with HT Grid.
All right. Thank you very much. And thank everyone from Volta for having me here to show our experience with this very exciting technology. These are my disclosures. And before I get into this, many of us have our own version of a redo AFib ablation. I'm sure everyone has their own type of what they do. Mine, before this technology, is I would typically do a CTI line that they had now. I'm up to 4. I would re-isolate pulmonary veins. I'm guilty of being a posterior wall isolationist. And then if they had preclinical flutters or atypical flutters, we would induce. And that was basically my practice for many years. I then saw this technology and incorporated that into my workflow. We'll show you a couple of cases. Our experience is roughly 40 cases, predominantly persistent, predominantly redos. I do have 2 paroxysmals today, and really they're probably paroxysmal bordering on persistent. They're both female patients, and so maybe my instincts were correct that the PVs were not everything. I'm an Insight user. I use GridX. That's my preferred mapping tool, and I use Tactiflex for my ablation. So our first case, a 70-year-old female that had a cryo PVI in 2015, had a redo PVI in 2018, also with a CTI line, and she started developing paroxysms of AFib, bordering on a persistent technical definition with recurrent atypical flutter and cardiomyopathy. So we brought her in for a case with Volta. Her CTI was blocked on the way in, and what you see on the top right, I like to make a voltage map of the left atrium just to get the lay of the land. And as this map concludes, what we'll realize that the right pulmonary veins remain isolated, the left pulmonary veins had reconnected, and like I would do prior to Volta, I liked to isolate the left pulmonary veins. I did do a posterior wall, and given that she had atypical flutter and AFib, we then went on to try to induce. And you see the map completing there, right PV is isolated. It looks like on the roof for reconnection the left veins. So then we went in for an induction, and what I'm showing you in the top left is the Volta screen that you see. This, because I use grid, you'll see a grid. If you use Penarray or Octaray, you will see that catheter. Similar, I presume, with Sphere 9, you'll see that catheter shape. And when it's, watch it change color as we go. And when color changes, that's the device recognizing temporal dispersion or investigating it. And then you'll see that. And we'll talk about that a little bit later. So again, it took a while to get our AFib going, but once we got it going, we started to map in AFib. And if you watch as we're moving the grid around, I know this is very high speed and hard to see these electrograms, but once we got AFib going, we had temporal dispersion. Right, watch the grid here. We see it turn red and those rings come out in the low left atrial septum. I know it's challenging with the voltage map overlaid. I'll show you that without that shortly. And here we come, watch me come back to the same area. What I really think is amazing is the reproducibility of this. So we come back to the same area shortly. And again, we didn't see any dispersion anywhere else, but here we are again, same area. We reproduced that high dispersion. So, and I just included this slide. What do you see when you're mapping an AFib? Well, the top left is relative organized atrial activity, and your grid, your Volta screen would look like this. As you move on to the top right, you see it looks disorganized or dispersed, but in the center of those electrograms, you see we temporally organized and back. It may investigate that area, but it may not produce any tags. So that's a sign you can move on. Here in the bottom left, this is an area that had enough temporal dispersion to register temporal dispersion, but it wasn't, I guess, high stability. And if you look at the bottom right, this is an area, this was actually the low left atrial septum that had temporal dispersion, high stability, which means a longer term, which was more consistent with a site of termination organization. So these are the kind of things you're looking for. If top left, you could move on. Top right, you can move on. Bottom two, wait and hold until you let the software have its time to analyze the data. We've done right atrial maps in virtually every patient. This was no exception. We did map the RA and AFib. Again, our CTI was blocked from before. We did get some high dispersion tags in the lateral, high lateral right atrium in this case, and in a cluster in the lateral wall. And we'll get back to that later. You see the grid turning red and those secondary rings coming in. So at this point, my thought was to focus on the low left atrial septum first, and then address these right atrial ones second, because there's going to be a hierarchy of these clusters, and I went to the highest cluster density, which is in the low left atrial septum. So again, the Volta screen is not active at this point. We're getting our tacticath here, and the orange dots are high stability dispersion points, and the purple are the moderate dispersion points. The bottom right is our Pruka screen, and you can watch the rhythm. And here we are ablating on the septum. Notice those white dots are denotating where the right wacka was from their prior case. If you watch the bottom, ablate this area, we terminate the sinus rhythm in this cluster. And at this point, we elected to consolidate this area, and we ultimately joined these two zones together. And you have a decision: do you go anterior toward the mitral valve to get to that isolated zone, or back to the right wacka? And here I'm showing we're moving back toward the right wacka to join the wacka to this area. And I'm not going to show all of it, but we went ahead and completed that portion, and then we came back and remapped. This area was isolated. Now back to the right atrium. Here were our tags in the right atrium. I've just terminated AFib. I have these tags. I think they should probably go after them, but I thought that could be close to the sinus node. And we made I'm glad I checked, because when we did this, sure enough, these were right around the sinus node. Now, it could be, portion of the crista terminalis. Because this was her third case before we ablated these, we actually did a pretty deep induction run to try to induce AFib, and we couldn't. And you can see this is a little bit better. There's our sinus node, and those orange tags were pretty close, so we elected not to ablate. Only seen this 3 or 4 times where we have tags near the sinus node. Again, this is this lady's third case. We really want to be sure we covered everything, but we did leave these. We did not ablate these zones. Our second case, another female, 50-year-old paroxysmal patient, had a radiofrequency ablation 2 years prior. She was becoming a recurrent AFib, started becoming more of a persistent, developing some heart failure, kind of early persistent type of patient. We did it. She also had CTI flutter as well as recurrent fib. So we took care of the CTI on the way in. And this is her map, is sinus rhythm, the left atrium, again, trying to get a lay of the land of what we have. And what we discover is that and you can see the remnants of portion of the left wacka set, and we have recurrence of both right and left veins on the ridge and on the right veins on the roof. So my plan with this was to re-isolate veins, posterior wall, and then induce. But as we were re-isolating the left superior vein, she spontaneously went into AFib. So we took the moment to go ahead and map while she's in AFib. And again, we watched the Volta page in the top left. It turns red. It's investigating. It gets deeper red, or the ring is red. It'll start laying tags down. We have temporal dispersion up on the appendage. So we have some dispersion here in the low posterior wall, RAPV. We then had dispersion. There it is again. We had dispersion in the again, left atrial septum again. And we had left superior vein appendage base roof connection, temporal dispersion there. So our tags were at that junction, posterior wall and low left atrial septum. And then I went ahead, I'll go to the next one. Then we went ahead and mapped the right atrium. We did have some tags in the right atrium. Again, there are only 2 or 3 compared to what we had in the left atrium. Once we completed mapping the right atrium, we went back to the left atrium to go ahead and start our ablation. Again, you can watch I think we get to the roof of the right atrium. We got some high stability tags right in the mid roof of the right atrium in this case. Right about there. You see those secondary rings coming in, showing us that we have some tags. So with this, my plan was to re-isolate the pulmonary veins from the left superior roof, make a roof line over to the right, because that's where the reconnection was. There were some low posterior wall lesions, kind of outside where a traditional posterior wall set would be. So I made a decision to make a low, scooped out posterior line to incorporate those, and then go to the left atrial septum. So we'll see what happens when we start ablating. Again, these are the high dispersion tags at the appendage base. We confirm that we re-isolate the left superior vein. And now as we come over to the roof line, the grids in the right RSPV. As we come over here, we then isolate the right veins. And then see the purple cluster in the posterior wall. As we come across here, again, kind of a lower scooped out posterior line. And watch here as we get to this junction. I know it's sped up, but it slows, organizes, and terminates AFib right in that purple cluster. The posterior wall is not isolated this time. So it wasn't where we got posterior wall isolation. It's when we went through that cluster. And so then we went ahead and finished off the posterior wall, did the low left atrial tags. And we did ablate those 2 areas in the right atrium. We did do an induction run post and did not stir up any tachycardia. So these are the same tools I was using before I had Volta. I'm doing a lot of the same things I did before. Yes, there is extra mapping. Yes, there is extra time spent. But for these people coming back for second or third times, I find this is a great tool for our patients to help keep them out of AFib. And I feel like I've done everything I possibly can to help them be arrhythmia-free. So again, the seamless integration, what we do, I think it's a great tool, and very happy to share these cases.
Michael, that was a nice demonstration of integration of InsightX with Volta. I mean, usually, the historical belief or data is that termination means nothing, right? Just because we terminate an atrial fibrillation episode. So has your approach changed any at all now for a lot of these redos or persistent cases where you have heterogeneous scar tissue and you know that substrate is not just going to be straightforward.
Right. I think what's changed for me is I'm looking at this, I've developed, there's some certain zones that I think our termination points organization are coalescing in certain areas consistent with data. And so I worry about overablation, just saying, ablate everywhere where the tags are. So
Especially with the bazookas we have in our hands and our eyes.
yes. And worrying about, are we in isolated appendages, or are we have a functionally non-conducted atrium? So my different approach is, I am trying to consolidate these in the area where I maximize as much atrial conduction as I can, while also targeting all the areas.
So when you drop in these lesions, so are you ablating a little less than you were ablating before? And what is the reinducibility of atrial fibrillation in these cases?
So as far as the power and the wattage?
No. In terms of the amount of tissue that you...
Amount of total tissue. I think I'm trying to ablate the high H tags. I might leave some of the moderate tags that are isolated, or that's a handful of them. So I don't think I need to go after every area of dispersion. I think the highest density. And so that's where I'm trying to get after. And then the reinducibility, there's some of these patients that don't terminate, that you have to make a decision of when you stop the case. And some of those patients maintain sinus rhythm. So we're seeing things that, that mirror the results of the trial.
But excellent. Thank you very much.
Thank you.
So Dr. Nair from Jonesboro, Arkansas, she's going to talk to us about the single catheter workflow for non-PV air-guided ablation.
Thank you, TJ. So I know the title sounds like I'm not doing much, but I will tell you that I went through the whole lifetime the way David was doing it, but I am known for not being as patient as David. So as 2024, when pulse field ablation kind of came into the lab, despite the fact they were bazookas, I fell for them. And one of the things I started missing was having Volta in my workflow. And initially, I would say early on, I would use the grid map, because I did miss having Volta, these redo cases especially, because it was one of those areas where I never knew what to do sometimes, especially if they came back, I've done my PPI and posterior wall already, and now what? I always got into those challenges, and I always pulled out Volta. And I would use the grid map and do the grid mapping, and then use Farapulse. But there was no elegance to it in my mind, because I was just almost mass destroying tissue. And that's the point where I started thinking more about, bugging the Volta team, if we could potentially start looking at maybe other more refined ways. And this is where I want to kind of talk about my workflow. So I'll start with my patient here. It's a patient, she's a female. We all have a thing for female patients. They're the hardest ones, no bias here. Persistent AF, recurrent atrial fibrillation, atypical flutter. She's had a PVI and posterior wall, and SVC isolation. So this was a persistent patient to begin with. And like David said, I always fall into the posterior wall category in those patients, especially if their anterior wall is to do a voltage map ahead of time. If they have a good anterior voltage, then I do the wall in those patients, and that's how I used to do it. My thing has changed now, but you can see that you kind of struggle. What do you do? And the patient's coming to you in a fib. Where do you go? When do you do the right side? So let me just walk you through this. And what I'm using here is the Sphere 9 catheter. And I mean, there's goods and bads to the pulse field system, but to me, this is a catheter I like to use for my redo cases nowadays, because it is a map and ablate catheter, and that's a workflow that I want to just kind of show. And mainly, I want to just kind of be part of this panel here, talking about the versatility and the flexibility of the Volta system with the different ablation tools. So I'll kind of place this here. Obviously, as I said, this is a, map and ablate kind of catheter, right? So I'm creating my Affera map. And just like David showed, now I'm seeing the sphere 9 instead of the grid in my Volta AF-Xplorer screen. And we're using the AF-Xplorer II. I like the AF-Xplorer II because it makes me do less work, and I don't have to put a lot of brain power into what's a higher area of dispersion and lower area. The system kind of tells you which areas that has the highest stability with dispersion. So when you see those red tags kind of go along, you can see we're mapping it's at a higher speed. And what I'm looking for is when those dispersion comes along, you'll see areas. I use different tags for different areas. So sometimes David did a good job of showing you the 4 quadrants of how certain areas you can avoid, certain areas you need to target. I tag areas based on where I see dispersion. Then I tag areas where there is dispersion with stability, where the AF-Xplorer II kind of shows you this is an area where there is dispersion and stability in the dispersion. And like this, for example. So this is an area that gets a special color. My mappers are pretty clear on, they don't mix up the colors. So those are the areas when I come back, I know that, I will start there. So I have this risk score in my mind. So like DJ was talking about, do you take all of them out or do you not? Depends on how many dispersion areas I see, how much voltage is left behind. I come from the state of Arkansas, but I don't like red maps. Having said that, you can see, we're doing the full map, and there are certain areas where, like Isabel said, especially in female patients, you'll see the anterior wall. And you can see in this case, the PVIs and the posterior wall looks pretty okay. I mean, there are certain areas where I probably would make it a little better. But you can see how there's good amount of scar along the anterior wall as well. And then there's the right atrium, and you can see the roof of that posterior wall. Of course, it makes sense that that is an area you would ablate, right? Even if you don't. But what also stands out is that's an area we ended up having a good amount of stable dispersion. So sometimes the voltage and the dispersion will match, but not always. And I tend to believe the dispersion more than I believe just the voltage. But in this case, a lot of that was concurrent. So here you can see we're starting the LA ablation. I did not map the right atrium in this case to begin with. I started in the left. And you can see we start ablation along that roof area. And that is the area where, the tissue is much thicker. My catheter is in the left side. And you can see I'm stacking those lesions there. And then I come along that anterior septum, which is where I had the next round of high stability dispersion point, and kind of connecting that or extending that anterior antrum on the right side to take it along that roof. Again, you're trying to minimize as much as you can, but you can see there's not a lot of saving I can do here. It's a lot. There's a lot of dead voltage here. But having said that, you can see as we're kind of ablating the dispersion areas, what we routinely see is sometimes we'll see termination into AF, but sometimes we'll see organization into flutter. And majority of the time, you're seeing organization into flutter. Now, you are tempted with a catheter like Sphere 9 to now start mapping the flutter. But I think I've gotten lazy. You can see we just started organizing here. The right EP might actually go and map that flutter, but I finished my dispersion tags. Because what I've seen with my experience is by the time I've finished my dispersion tags, many a time it organizes into a CTI flutter, and then I'm done. I don't have to kind of do another map. But this is one of the reasons I like this this catheter, because if I do have to stop and remap again, I'm not exchanging catheters. It is a single catheter workflow, and I can kind of go on to finishing. But this turned out to being, we actually ended up ablating the CTI. We entrained, and there was CTI flutter, and you can see we're coming along and doing RF along the CTI line, which is what I usually do. And the plan was that if I finish doing this and if we terminate, and the idea is that after we terminate, we do reinduce. We give isoprol. We usually do 20 mics for 10 minutes, especially if the patient doesn't have any CAD, etc. We'll do, here you can see we terminated into sinus as we finish that flutter line. But the idea is that after we do this, I'll try reinduction. Now, I mean, in a patient like this where I know there's so much scar and there's so much to do, if I do reinduce and I don't get dispersion, I don't ablate anymore. I'll cardiovert them back and take the time, because what I've seen is that they do okay. But if they go into a fib again, I will actually map the right side first to see if I'm missing right-sided triggers, because I think we forget that atrial fibrillation includes the right atrium as well. So you can see kind of that final map. Yes, there is quite a bit of ablation, but not as much as I would have done if I did just an empiric ablation. I probably would have taken the anterior wall. I probably would have done the appendage. I probably would have done the posterior mitral isthmus, because that's what my brain tells me to do, because that's what I did historically, but that's not what we did here. I'll quickly share another case. It's a 71-year-old male. Wanted to be unbiased here, so there you go. Persistent AF, again, recurrent atypical flutter. I do want to say this is not the only patient that I use Volta, but this is my favorite patient with Volta, because I like termination, and it makes you feel better, like you're doing something. So you do get a pretty high level of termination when you use the system. So this patient had an RF PVI in 2021, and we're again coming back to doing the map here. I let the map run. And DJ, I just want to ask you. I know I'm showing Sphere 9 as my catheter. I know everybody uses different catheters for their redo. I get that there are many high density catheters, but is that something that you've seen that I can still continue to do?
Yeah, I mean, absolutely, because you really need something where it gives you the ability to precisely do multiple things, not just one thing, right? Single shot catheters obviously are limited in their scope, especially in redo cases where you may have to do non-PV areas, whether you had to homogenize or you want to take out the lateral wall. And so I think Sphere 9 gives you that versatility with both RF, PF. So I think once the other single tip dual energy catheters get approved, I think the level playing field will be much different.
Much different. And you can see the map here, right? Like the right veins are okay. The left veins have some reconnection.
Right.
There's scar along the anterior wall. And the posterior wall also has scar. So this is the patient I really start worrying about, where all do you ablate? Do you take the posterior wall out? There is scar along the anterior wall. What happens to that patient at that point? Even though it's a male, sometimes males have anterior scar too. So
did they try to do an anterior line in this case in the past?
No.
That's interesting.
Yeah.
Yeah.
Oh.
Right.
So again, importance of mapping in cases. I think there's a lot of move towards let's just go and ablate. It's very, very important to do a high density voltage map and substrate map. And if you can use Volta. But I think the idea is that you got to know what you're going after before you go and ablate. And like DJ said, we have bazookas, but with great power comes great responsibility. So just, kind of keeping some of that atrium intact, I think is very important. And you can see where the tags are, and I'll kind of play here where we go and for the ablation. So I kind of focus on whether I want to do the posterior wall or not based on if I have dispersion in the posterior wall. In this case, we had dispersion along the roof and the middle of the posterior wall. And you can see we terminate into flutter. But again, back to that scar and the scar and the dispersion along that the low area along the inferior wall there. You can see I'm going really low, just like you did, David, because just to incorporate those dispersion points, because I don't always come that low with my posterior wall, even though Andrea would say that's the way to do it all the time. I don't routinely do that way, but in this case, I did it that way. And I reinforced my PVI, even though the right veins were isolated, because I still had dispersion along my anterior interim, along that right vein. So I went ahead and reinforced all of that. Previous ablation was RF, so I figured new technology, new modality, why not? So we ended up doing a whole PVI, doing a PVI posterior wall in this patient, kind of one big box to kind of, I would say, consolidate all of that. Then we go into Flutter 2. We actually change, and then as we're ablating along that dispersion along the lower end area, you can see there, we terminate again. Now I'll just show you the final dispersion map. I mean, there's not as much dispersion here. You can see that. So how much if you look at it, the reason I still believe in PVI and durable PVI. So once I did the durable PVI and took the roof out, there was a flutter along the inferior aspect. So you still have to be an EP, do your entrainment, follow that, but you can decide on how much you ablate based on just the dispersion. And here's the final ablation map. Would I have ablated more if I didn't have Volta? Probably not. I would have done the posterior wall, but I would not have done that anterior part. But in this case, we did. We did check the left atrial appendage as well to make sure we didn't isolate it. So I guess this is the data from the work that we have done with this catheter and with Volta, and we presented this data before. This is data from 10 patients, very small subset, but it was dramatic enough that I felt, I feel the need to kind of share this data. This is using AF-X2, so very recent data. You can see 42% were female, 10% de novo, majority redo, because that's what I use my Sphere 9 catheter for. Procedure times, I know David said these procedures could be longer, but I don't think this is that long especially with a single catheter workflow. I think it's very reasonable. You can see the number of dispersion points. We're not talking a large number of dispersion points. That's what AF-Xplorer II does to you. It kind of cuts down from what we saw from tailored AF, the number of areas, to what we see now. You can be more judicious. And you can see about where the LA RA was. About 7 or so were in the LA, but majority, we also saw many in the RA. And 80% of patients had AF termination, 20% converted to atrial flutter and required that. We didn't have to cardiovert any of these. And I mean, these are patients that, otherwise can be pretty challenging. So I'll stop with that. And to me, this is kind of my intuitive workflow for a redo case now. It kind of helps you use whatever system you want. You saw the different systems. You can pick and choose your ablation system, and you can pick and choose your mapping system and and still do justice for your patient. Thank you.
So, Devi, I have maybe more of a foundation question, right? So, most of the dispersion piece of it, as dispersion as a base unit, historically has been measured with high-definition catheters with bipolar system, right? With Affera being an extended unipolar, how does the system adjust for detection of the dispersion? Because the electrograms or the iterative electrograms are different when you're looking at the Affera system versus you're doing when you're doing the HT grid or grid X or octopolar, like the octa-race and stuff like that. Any thoughts on it?
I think from my understanding, and I see Jerome sitting in the front and he's itching to answer that question, but I will say that in my understanding is that, the signal quality is still very clean with the Sphere 9 catheter. It has small multi-electrodes, gives you, it's unipolar signals you're seeing. You're seeing signals in a different way. I probably would not pick it up with my eye. I think on a grid, I probably will say, okay, this is probably going to be dispersion. But on a Sphere 9, I would never call it, whereas the system does. And I'm assuming they are filtering the signals to get that. Jerome, you want to?
Yeah, Jerome, why don't you come over?
Come over. We have a seat.
Yeah, we'll take the mic. the in-house expert.
Yes.
Thank you for inviting me to respond to this question. Thank you for this great presentation. Yes, exactly. You said it right. There is a set of filterings and a set of learning that we were able to obtain from adapting our algorithms to the Sphere 9 catheter. And I would say one aspect that actually you described, DJ, which is the neighborhood analysis, is actually more true even for the Sphere 9 paradoxically than it is for larger catheters, because there is more redundancy between the micro neighborhoods that you are analyzing. So this increased redundancy actually makes the analysis with this catheter very interesting.
So the other point, as you kind of map through it, sometimes the AFib organizes and becomes more flutterish, and then it gets disorganized. How does the system automatically eliminate these organized portions on the time chunk and only rely on AFib portions? How does the system count that?
That's a great question. And in fact, Michael, you showed it very, very well, that you have indeed some areas where you have really dispersed regions and then reorganization and then dispersed again, as you are describing. In fact, that was a topic for many years at Volta on how do we effectively get rid of these regions, or at least present them differently to the operator. And this is why you saw the high stability areas versus a relatively normal stability area. And, and Theo here and the rest of the team really worked hard to get this right. And I think we are getting closer to getting this right. And I would say what's coming probably next year, we'll get it even a step further because it will integrate into the analysis some 3D information.
Okay. No, I think this definitely is pretty exciting. You've done all the trials. You have an FDA indication. The next question is, in your journey, how do you aim to put this tool in the hands of clinicians that they can actually use it? What's your rollout plan? What is your reimbursement plan? How far are you getting a new code for this? I know that you guys have been feverishly working on it. Can you tell us more about where this is going?
Yes, thank you, DJ, for asking this question. Indeed, we are present in a few centers in the US, progressively more centers in the US and obviously more centers in Europe. We are having more and more operators who are actively requesting the system. And in fact, they are helping us in our reimbursement effort. Many of you here have helped us actually reach out to CMS and say, hey, we have some patients here that we would like to use with Volta, maybe not all our patients, but some of the patients. And we need CMS to take this into account. This is an ongoing effort. And obviously, we deeply appreciate the role of the society in helping us understand how to interact with CMS. We had some very recent interactions that were extremely effective. And so it's going to be an effort that really goes beyond even Volta, because we really want the digital medicine and AI for digital medicine to enter in the EP lab, whether it is Volta or another company.
Yeah. I think this is the new frontier. You guys have been sort of pioneers in the space ahead of many others. There are a lot of people that are trying to come and follow your footsteps. So I really love this idea of really creating this ecosystem, of creating a powerful feedback loop with AI machine learning involved and really creating a dynamic ablation target system. So thank you very much. And I really appreciate both you, Devi and Michael, for really sharing your thoughts with us. This will be a wrap.
Thank you.
Thank you. Thank you very much.